We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome in today's Pinch of Salt, a series of podcasts created by the ERA. I'm George Kosmadakis, your today's host, and the subject is obesity and chronic kidney disease. The pathophysiological interconnection between obesity and chronic kidney disease is well known, and the effects of weight-controlling treatments in the protection of renal function is coming to surface. But we are actually in the middle of an obesity pandemic, especially in what concerns younger patients that might compromise the well-being of several generations to come. How medicine can navigate through this situation? Our guide today is Dr. Marieta Theodorakopoulou from the First Department of Nephrology, Hippocratean Hospital, Aristotle University of Thessaloniki in Greece. Dr. Theodorakopoulou, welcome to A Pinch of Salt.
Hello, and thank you very much for having me on the podcast. I'm really excited to be here today and talk about a topic that's becoming more and more relevant in everyday clinical practice, the association between obesity and chronic kidney disease.
Wonderful, wonderful. Well, I knew that obesity is becoming a health problem, but I didn't know that its prevalence is expected to exceed 50% of the global population by 2035. That is in 10 years from now. It's unbelievable. So what is the impact of obesity in chronic kidney disease?
Okay, you are right, and let's take a moment to look first at the broader picture because obesity is one of the most pressing global health challenges nowadays. Over the past several decades, the global prevalence of obesity has skyrocketed, reaching epidemic levels in low, in middle, and high-income countries. As of 2021, around 2.1 billion individuals worldwide, that's almost 50% of the global population, were living with overweight or obesity, and the trend is accelerating. Forecasts suggest that, as you have also said, by 2050, nearly 60% of the global population will be overweight or obese. And this rise has been dramatic across both sexes and in all ages. Even among children and adolescents, the global obesity rate has more than doubled in the past 30 years. Now, beyond all these numbers, the health burden is enormous. In 2021 alone, obesity was responsible for 3.7 million deaths and over 130 million disability-adjusted life years. It's become not only one of the leading risk factors for global disease burden, but also the fastest rising one. It has been associated with increased risk of several chronic diseases, diabetes, cardiovascular disease, and cancer, and it leads to significantly higher cardiovascular and all-cause mortality. This surge in obesity is now driving in parallel the increases in other major chronic diseases, type 2 diabetes again, cardiovascular disease, and all of which are associated with higher mortality. One recent forecast even suggests that due to obesity alone, more than 1.3 billion people could be living with diabetes by 2050. And now, what about chronic kidney disease? There is a growing body of evidence showing that obesity is also a significant risk factor for chronic kidney disease. While part of that risk is mediated by the higher rates of diabetes, of hypertension, and the other cardiometabolic comorbid conditions, we all know that obesity can independently increase the risk of developing CKD, even in people without diabetes. Obese individuals are at great risk of reduced glomerular filtration rate and also albuminuria. There are many studies showing that obesity increases the risk of both reduced kidney function and albuminuria, even in people without coexisting diabetes. A meta-analysis of such cohort studies with more than 6,000 individuals showed that obesity is associated with 20% higher risk of developing low GFR and 50% higher risk of developing albuminuria over the 5 years. Long-term cohort studies also reinforce this risk. For example, there is a 40-year follow-up study of the Israeli army recruits, which showed that the risk of developing kidney failure was 3 times higher in individuals with overweight and 7 times higher in people with obesity compared to those with normal weight. And when obesity and diabetes coexist, this risk jumps dramatically up to a 19-fold increase. Of note, the strongest evidence that obesity independently increases the risk for CKD comes from a Swedish twin registry study in which the twins with a higher BMI were more likely to develop both CKD and type 2 diabetes over a follow-up period of 12 years, even after adjusting for the shared genetics and lifestyle factors. The 32% of the CKD cases were attributed to being overweight or obese alone, and nearly half of those occurred in people without diabetes, highlighting that obesity is an independent risk factor for CKD. The relationship between obesity and CKD is mediated through both direct and indirect mechanisms. Directly, obesity leads to severe changes in the renal hemodynamics and can cause the known obesity-related glomerulopathy. Indirect mechanisms include the activation of the renin-angiotensin and aldosterone system, the release of adipokines that promote the kidney lipotoxicity, and the chronic inflammation, increased oxidative stress, and, of course, insulin resistance. All these factors on their own or in combination with the comorbid conditions like hypertension or diabetes or previous kidney disease raise the intraglomerular pressure, promote proteinuria, and lead to a progressive loss of the kidney function.
Wow. So talking about an epidemic condition, and it's not only diabetes, it's also all these obesity-related chronic kidney disease conditions due to hyperfiltration, FSGS, hyperactivation of renin-angiotensin system, kidney lipotoxicity, oxidative stress, you name it. A huge number of risk factors that are compromising the kidneys. And in front of us, there is a situation that is it is like a fire that is going on. We should do something. We should do something. So we go to the next question. How should we coordinate treatments in obese chronic kidney disease patients? It's a huge number. I think we should have a coordinated strategy.
Yeah, and here is where the things are really get interesting and also a bit challenging. Managing obesity in patients with CKD is a critical part of the care because weight loss can improve also the blood pressure levels, can reduce proteinuria, improve the cardiovascular profile of our patient, and of course, slow the CKD progression. It requires a careful and personalized approach. Treating obesity in CKD needs a multidisciplinary approach. Nephrologists, dietitians, and sometimes bariatric specialists are needed. Let's talk about the lifestyle interventions. First, we know that lifestyle measurements are effective treatments for weight loss and have been associated with improved kidney outcomes in obese individuals. But achieving and sustaining the weight loss is a difficult thing. Many patients can lose weight in the short term, maintaining however, that loss long-term succeeds in only a minority of the cases. That's why structured educational programs have been developed to support this lifestyle change. For example, we have the diabetes prevention program, which used individualized counseling on diet, on physical activity and behavior, and it achieved an average of 5 to 7% of weight loss and reduced the incidence of type 2 diabetes by 60% over the 3 years. Similar programs have shown that frequent and long-term contact with the healthcare providers helps to improve the outcomes, even if the weight loss is modest. So, how can we start? Where do we start? First, we need to get to know our patient, their social setting, their food environment, and the motivational level matter. Personalized nutrition is the key. We can use tools like food frequency questionnaires or recall 24-hour diet, along with diet tracking apps. All these can help to assess the dietary habits. Then, also working with a renal dietitian, we can develop a safe meal plan that lowers calories but preserves muscle mass and prevents the malnutrition. Many weight loss programs include restrictions or encouragements of certain food categories, macronutrition composition adjustment, and time restricted feeding, for example, the intermittent fasting, which generally have an effect on weight loss and improvements in the overall profile of the metabolic syndrome. Interestingly, these patterns, for example, plant-based, minimally processed diets and fiber-rich diets, may slow the CKD progression, and also a high fiber intake associates with lower inflammation and all-cause mortality. The protein intake should also be individualized. Too little causes muscle loss and cachexia and sarcopenia, but too much, especially if this originates from animal sources, may increase the remic toxin levels. In general, also the KDIGO suggests 0.8 gram per kilogram of ideal body weight per day as the target for patients with CKD. Now, and while the diets tend to have the biggest impact on weight loss, physical activity also plays a crucial supporting role, especially to maintain the weight loss over time. People with CKD often have lower physical activity and cardiorespiratory fitness levels than the general population. In these patients, regular exercise is both safe and beneficial. It improves the cardiovascular fitness and the quality of life and helps to reduce sedentary time. And of course, it preserves the muscle mass, which is vital during the calorie restriction in CKD. Again, we have the recommendations say that all patients should have at least 150 minutes of moderate intensity activity per week. And finally, we also have medical therapy. We have fantastic medication now, like GLP-1 receptor agonists, semaglutide, and the dual GIP and GLP-1 receptor agonist tirzepatide that support both weight loss and cardiovascular and kidney protection. These are game changers, and they may also soon play a role even in non-diabetic population. And for patients who do not respond to this lifestyle and pharmacological interventions, we also have bariatric surgery. It's a valid and evidence-based option. It is much more effective in weight loss than the low-calorie diets, and is an accepted treatment option for patients with severe obesity. It can improve GFR levels, it can improve albuminuria, and also, do not forget, improve the access to kidney transplantation and reduce the long-term morbidity and mortality. To sum up, weight management in CKD is complex, but it's also highly impactful. We need a team-based, a personalized, and a sustainable approach. And even if no single intervention does it all, altogether, these strategies can make a real difference to help our patients in this matter.
So the tools are there, and we should combine them in order to have the most optimal results. And I think you answered during your previous answer already, but I would like to stress this point. Do you account for the ideal or the actual weight to prescribe therapies?
Okay, this is a really important and a practical question. The answer is simple. It depends on the therapy and on the patient's body composition. For example, for many therapies, we can choose between the ideal body weight, the actual body weight, or sometimes the adjusted body weight, and it depends on what the weight is being used to estimate. For example, for the dialysis dosing and for the estimation of KT over V, we typically use the ideal body weight to estimate the V, the total body water, because using the actual weight in obese patient can underestimate the adequacy of the dialysis. For drug dosing, for example, for erythropoietins, we often start with actual body weight, but adjust based on the response of each individual. For other antibiotics, for example, for aminoglycosides, which are mainly hydrophilic, we use the ideal weight or the adjusted weight in obese individuals. For anticoagulants, we typically use the actual weight. For other situations, for example, for nutritional prescriptions, to estimate the protein or the calorie needs, we use the adjusted body weight to avoid the overfeeding in obesity or the underfeeding in patients with malnutrition. And when estimating the kidney function using the Cockford-Gold formula, we use again the adjusted weight in obesity patients and the actual weight in normal weight individuals. So in summary, it's not black and white. We have to be deliberate about the pharmacokinetics and the therapy we use in this case.
Right, right. So we should choose according to the situation. Well, my next question is the last medical question, and it's based on the fact that, dear ladies and gentlemen, Dr. Theodorakopoulou was the first author of an article appeared in September in NDT concerning the SELECT study, and she will talk a little bit more, I think, later on. And while she will be answering the question, are there any renal data on the anti-obesity drugs?
Yes, we have now strong evidence. Among the available pharmacological options we have in obesity, GLP-1 receptor agonists are being increasingly used, and we have major trials demonstrating long-term efficacy and sustained clinically meaningful reductions in body weight. But in addition to this documented weight loss, GLP-1 receptor agonists also have kidney protective effects. We know in patients with type 2 diabetes and CKD, we have data from meta-analysis of the cardiovascular outcome studies showing that GLP-1 receptor agonists improve the composite kidney outcome that consisted of incidence of macroalbuminuria, doubling of serum creatinine, or decline more than 40 in GFR, kidney replacement therapy, or renal death. We have also recently published the FLOW trial showing that semaglutide reduces the risk for major kidney events as a primary outcome by 24% compared to placebo. As for non-diabetic individuals, you have also said that the evidence came from the SELECT trial. This trial included more than 17,000 non-diabetic individuals who were overweight or obese and had established cardiovascular disease. In this study, semaglutide not only reduced cardiovascular events by 20%, but in the secondary kidney analysis, it also reduced the composite kidney endpoint by 22%, and this benefit was driven mostly by the reduced incidence of macroalbuminuria and the onset of persistent higher than 50% reduction in GFR. And this effect was stronger in those who had lower baseline kidney function. Interestingly, about 80% of this kidney benefit was explained by the weight loss, and that's not the whole story. GLP-1 receptor agonists also reduce inflammation, improve endothelial function, improve fibrosis-related pathways, and have beneficial hemodynamic effects. So there is likely a multifactorial mechanism behind this kidney benefit with these agents. Another drug option is tirzepatide, a dual GIP and GLP-1 receptor agonist, which has recently launched as an effective drug to reduce body weight in obese individuals and also to effectively maintain normoglycemia in patients with type 2 diabetes. In the clinical trials of patients with diabetes, 50 to 20% reduction in body weight was seen with tirzepatide, and there was also an effect on glycated hemoglobin, about a reduction about 2 percent points. It is generally safe. It does not induce hypoglycemia unless it is combined with other agents. And we have data from the SERPAS program that tirzepatide not only reduce albuminuria, but also slower the GFR loss and the rate of decline compared to insulin glargine alone. Now, alongside with GLP-1 receptor agonists, we should definitely mention also the SGLT2 inhibitors, which today, together with the RAS blockers, are the standard of care in patients with CKD. They originally launched as glucose-lowering drugs, but SGLT2 inhibitors soon proved to have pleiotropic effects. They provide important cardio and kidney protection in all CKD patients. We should not forget that with these agents, we can also have modest weight loss, about 1 to 3 kilo. And this has been also suggested to contribute, along with the other many mechanisms, to the powerful effects of these drugs.
Right, so we have pleiotropic effects of these very exciting new categories of drugs. Hope is there. And with this, I will get to the get to know you personal question, Marieta. If you were in a desert island, which book, luxury item, and 2 songs would you take with you?
Okay, the book I would bring would be a cookbook, probably, because not only good I need to get creative with all this tropical food, but also a great cookbook can also be a travel story, an art book, and a manual for survival for
Very
me.
original.
Yeah. Now for the luxury item, this would be probably be my laptop. It's my portal to memory, to creativity, and hopefully it is a way to keep in touch with my family and the people I love. And for the songs, I would pick Scheherazade. This is my favorite symphonic suite by Nikolai Rimsky-Korsakov. It is based on the 1001 Nights. It is reflective, atmospheric, and it is, I think, the perfect song to lying on the beach and thinking about the world I left behind. And the Here Comes the Sun by the Beatles for its hopeful energy that is perfect for a beach morning.
Wonderful, wonderful. But the cookbook was really original. Thank you very much, Marieta. Dear friends, as you see, there are solutions, but we should not, in any case, cry victory. We need to treat our patients for all the risk factors that might affect their kidney health, including this silent killer named obesity. We hope you enjoyed the discussion as we did. More podcasts are available in all the main digital platforms. Take care.